All right. Well, I guess we'll get started.
Yeah.
Yeah. So I know we have well over 100 folks already joining on the line here with us for this very special presidential lecture. And I, first of all, just wanted to welcome everybody. Welcome all of you back to the presidential lecture series, virtual for now. And I wanted to thank everybody for joining us. Today we have a very special lecture, one that was actually scheduled, or at least the speaker was scheduled before the pandemic, and all of that had to be canceled. And we're fortunate to be able to have the same speaker, Professor Agnes Binagwaho, agree to speak to us today, virtually from Rwanda. And of course, like all of us, the past few months have changed her perspective and her thinking a little bit, so the title has changed a bit. Before I formally introduce our speaker, I'd like to recognize and welcome our Board of Governors Chair, Carol Siegel. Thank you for persisting and joining us, Carol. I think we have our CEO of our system, Dr. Ranga Krishnan, on the line. We have our Provost, Sue Freeman. We have university deans and vice provosts. We have a number of distinguished guests. I won't list them all, but I know we have Lori Gillard, who directs our transfusion program, who's very excited to be working more closely with Rwanda, and some of her colleagues with us. We have some students and all of our guests, and again, I welcome all of you. It's now my distinct pleasure to introduce Professor Agnes Binagwaho, someone who has been an inspiration to me, as she is to many healthcare leaders around the globe, and someone who I'm honored to say has also become a dear friend. Professor Binagwaho, MD, PhD, is a Rwandan pediatrician who returned to Rwanda in July of 1996, 2 years after the 1994 genocide against the Tutsis. Since then, she has provided clinical care in the public sector, served the Rwandan health sector from 2001 to 2016 in multiple high-level government positions, first as the executive secretary of the Rwanda National AIDS Control Commission, and then as permanent secretary of the Ministry of Health, and for 5 years as Minister of Health. She co-founded the University of Global Health Equity, an initiative of Partners in Health, which focuses on changing how healthcare is delivered around the world by training global health professionals who strive to deliver more equitable, quality health services for all. Professor Binagwaho currently resides in Rwanda and is the Vice Chancellor of UGHE, the University of Global Health Equity. She's specialized in emergency pediatrics, neonatology, and the treatment of HIV/AIDS. She completed her MD at the Université Libre de Bruxelles and her MA in pediatrics at the Université de Bretagne Occidentale, and my French is really bad. She was also awarded an honorary Doctor of Science from Dartmouth College and earned a Doctor of Philosophy from the University of Rwanda College of Medicine. Professor Binagwaho currently serves as Senior Advisor to the Director General of the WHO, the World Health Organization, and is a member of multiple advisory boards and boards of directors, including the Rockefeller Foundation Board. She's a member of a number of international working groups and task forces in global health for the UN and other independent organizations, and also sits on the editorial board of many scientific journals and serves on multiple scientific commissions. Previously, she co-chaired the Millennium Development Goal Project Task Force on HIV/AIDS and access to essential medicines for the Secretary General of the UN under the leadership of Professor Jeffrey Sachs. Professor Binagwaho also chaired the Joint Learning Initiative on Children and HIV/AIDS, 06 to 09, and founded the Rwandan Pediatric Society, chairing it till 2019. Since 2016, she has been a member of the American National Academy of Medicine, and since 2017, a fellow of the African Academy of Sciences. In 2015, Professor Binagwaho received the annual Rue Prize and Ronald McDonald House Charities Award of Excellence. She is currently a senior lecturer in the Department of Global Health and Social Medicine at Harvard Medical School, a professor of pediatrics at UGHE, as well as an adjunct clinical professor of pediatrics at Dartmouth Giesel School of Medicine. Professor Binagwaho's academic engagements include research and implementation science, research on human rights to health, health services delivery system strengthening, HIV/AIDS, and pediatric care. And in all of those works, she has published over 190 peer-reviewed scientific publications. So please join me in giving a great virtual welcome to Professor Binagwaho, who today will discuss the moral imperative to build an equity-based health sector prepared to respond to health threats. So I don't know how we all clap, but I'm going to clap for all of us. I'm so excited to have you, Agnes, and I'll turn the floor over to you for about 45 minutes or so. So thanks again and welcome. I think you're still muted, Agnes. There you go.
Okay. So thank you so much, President Sherin, for welcoming me so warmly. And it's my pleasure, distinct pleasure and honor to contribute to your presidential lecture, Sherry. I want to recognize my sweet friend, Carol, who is there. I can see you, Carol. It's so great to see you after those lockdown and we're supposed to be together. And it's already a little something to be together virtually. So today I'm going to discuss with you how we build the Rwandan health system and how building it based on equity, it has prepared us to really be resilient in front of a threat like COVID. So the objective is really to show the progress we made during 25 years, having policies that centered to the people, and always for everything I'm going to talk to you about, have in mind that our GDP is 826 per capita. And in comparison, we can say that for the US, it's more than 50,000 per capita. That means, you go too fast, Mary. That means that what is important to say is really how we create the system. So, and what we did to do that. So first, I will talk about the story. It's important. And after that, how we build the health sector. And I will continue by the challenges we still face, because we face a lot of challenges, but also what is the way forward through education. Next. So Rwanda, it's in the heart of Africa. And really, in the middle, on the left, it's really in the heart of Africa. And I hope you have done your homework and see, preparing the subject today, you know where it is. Next. We are around 12 million inhabitants, and the majority have under 20 years old. And it's a very dense country with 483 people per kilometer square. Important to know that we are landlocked. We don't have a sea, so everything is coming through road or through plane. And in a period like COVID, it's very important. And the majority of the income are through agriculture. Next one. 25 years ago, we had one of the worst genocide of the last cycle, and we have overcome it. And today, next one, through reconciliation, forgiveness, and also try to understand how, and it's very important when we see the world unrest today for more justice, how it's important to the reconciliation process is important, and how to understand how people are manipulated by bad leadership. And if in a country like mine, where we face 1 million deaths over 100 years, and we have managed to come again together to rebuild the country together, that means every everything is possible. And no country should say it was too long, it's too late. With good leadership, we can make it. But 25 years ago, we had the lowest life expectancy, below 29, and we became more poor than ever. Next one. Over the 25 years, you can see the growth of the GDP, even if we're still low among the poorest country in the world. The life expectancy has grown. You can see it at almost in a parallel way. And you can see that even if we are not the poorest, if we are even better in our life expectancy than our neighbor that are more rich than us. The GDP of Uganda is 3 times ours, for example. Next one. And during those 25 years, we have doubled the life expectancy, reduced child mortality by more than 75%, reduced maternal mortality by more than 80%. And today, we have 91%. And those are the data from 2015. Today, we are doing another DHS, and DHS are very reliable survey done by the CDC with the support of Macro and the UN. And we had 91% of the women that were delivered their baby in a health facility with a nurse, a doctor, or a gynecologist, knowing that the majority deliver with nurse. When I came in this country, the rate was 20%. All the others were delivering at home. And not because they wanted, it's just because there were not enough skilled people and there was not enough health facilities. Next one. And you can see that the child mortality decline is not due to the amount of money invested, because you can see that many of our sister countries have invested more per capita in health, but for less results. We have invested the less for the most rapid decrease ever of child mortality. This is important because it's what you do with your money, how you invest it to create health that counts. Next one. Next one. So how we did it is not magic. I want to insist here that we put ideology, guessing, and say things will come right. Nobody went in that journey. We chose to go for capacity building, for scientific evidence, and we knew that because we don't have money, we need to innovate. We need to do more with the money we have. So everybody was put at the task. Next one. And we knew also that the future was ours. Our past was horrific. But the future depends on us. So we decided to really base everything on leadership, empower the people at community level and all level, create resilient institutions. Whatever we decide, we need to go through evidence. And I remember when I was a minister, when I proposed a new policy, I had to reference it like a peer review article, meaning they ask the proof that it will improve the life of Rwandan. And also what is in the heart of everything based on equity. We had to prove that we improve the life of the poorest and also involve the community in the design and never work alone. The Ministry of Health, the health sector is nothing. If you build a magnifique, a beautiful health center somewhere, if there is no road to get there, it's useless for the population. If there is no electricity, you will not be able to work properly. So work with the infrastructure, but also the local leader, the education, work together. Next one. So also accountability. each and everyone has to be accountable, and fighting corruption, and focus everything on human development. Meaning, if you have a little amount of money, how are you going to develop and focus on the vulnerable? And knowing that in all countries where they are vulnerable, the women are the most vulnerable. So focus on the poorest women and see how you can do something to develop them. And I used to say, Shireen, that the day the grandchild of the poorest woman in Rwanda is safe, my grandchild will be safe also. So working for the most vulnerable really is working for everybody. And also take health in an holistic manner and don't lie. When I say trust now, it's a new social determinant of health. And it has been proven by some studies done by Wellcome Trust, like in the US a year ago, if there was this crisis of vaccination against measles, it's because the population have distrust in the health sector. And if you find that in Rwanda, we are, I tell you, with the money we have, the support we have the best children vaccinated on us, with 11 vaccines for boys and 12 for girls because they receive HPV, at more than 93%, fully vaccinated for all those vaccines. It's because the population trusts. And this is so important that trust generates health. When we go outside and we say, this is the reason why you have to wear a mask. This is the reason why you have to be locked down in your house. This is the reason why there's something really we don't like, but we have to do. People doesn't believe you have a political agenda behind. They know that you do that to protect the majority. So trust is really a key pillar of everything we have done, and leave no one out. And it's so important that the day we had the capacity to treat the first people with HIV, we had only 3,000 doses. We need more than 100,000. And the people didn't fight for it because they knew that the selection was random, that it was fair, and working together, we will reach more quickly to the capacity to treat everybody. So, and have integrated a model of care. Don't put treatment of HIV in a corner. Don't make people travel miles for something and after that have to travel other miles for doing something. Bring the care where the people live and bring the holistic, the way to follow everything the people need, except when they need now a doctor or a specialist. They can go to the hospital, from the hospital to the teaching hospital if needed. Next one. So everything was based on equity, and this is how we created this insurance called Mutuelle de Santé, where 25% of the population paid nothing because they have not enough to pay. It is $5 per capita, and with this, people have access to all the primary care and refer to district hospital or even above if needed when it's requested by a specialist with authorization. So having this is mandatory. But what is good, as we put in the law, that for those who cannot pay, the government is obliged to pay. And also that 13% of the entire health sector budget has to be dedicated to access to that health insurance. And it's also the only way, because the majority, I have shown in the beginning, have work in agriculture around their home. So they are self-employed, but it's complicated to show the revenue. So it's the same for everybody. And it's a health insurance that works well for the informal sector. And in Africa, the informal sector is one of the big sector. Geographic barrier And equity means a village is it's about 100 to 200 houses. There are 4 community health workers in each village, elected by the people and educated by the Ministry of Health. And 7 villages make a cell. And each cell, we have a health post with a nurse that is at the level of secondary school. And 4 cells around make a sector with 15,000 people with the health centers and nurses. So creating taking the frame of the administrative structure of the country allow for geographic equity. Even if there is not enough for everybody, everybody has access averagely to the same thing. And social and cultural, that is education, explaining to people what we want to do with them, doing it with them, and also listen to them. Next one. So when you break barrier, you give access, you need also to create a solidarity and a collaboration. The Ministry of Health will reach nowhere alone without the collaboration of the population. And for this, you need to give agency to the community, make them participate to the healthcare, explaining how best can we treat and prevent malaria when we explain to them what it is. And also take advantage of any innovation that's happened in the world. That's how HPV vaccine, when we heard that it was there, we rushed for it and tried to have it in the country. Having a gender focus, I'm pleased to say that we have the parliament that have the biggest number of women in parliament, just because it was really a national agenda to have women in equitable access to all positions. So ensure that that whatever we do in all sectors and in the health sector also is to breaking the cycle of poverty. Next one. And this is the result. You can see that you have different quantile, and the gap, equity gap between the poor and the rich are going down. Really, now it's even better if the child of a poor woman have the same chance to live. And it's not enough because children are still dying too much. It's not the paradise. But if the child of a poor woman has as much chance to survive than a child of a rich woman in this country, that means the work is done. Now continue to improve on quality and on access to everyone. Next one. So this is what I described to you, the decentralization system. Below is the village with community health workers. For village, it's a cell with a first place you see a nurse. After that, we use the next step is the health center where you see nurses with the gray. After that, you have the hospitals, you have the district hospital, the provincial hospital, and above all, what is in cities, a referral hospital and teaching hospital. Next one. So make sure that you respond to the need of the people. What are the major killers? And make sure that you can respond to that where the people live. And also, remove the fact that you need to be specialized to provide family planning or treatment for pneumonia or treatment for malaria, etc. Educate community health workers to provide those services with syndromic approach have really made the difference. So make it at community level. Remove that from health facilities. Everything that can be removed is also key. First of all, it is the people are more concerned, participate more, but it's also less expensive than to create hospital in every corner. We don't have the money for that. Next. We start tackling the non-communicable disease since a couple of years, and it's important because soon there will be 28 million additional deaths due to non-communicable disease. We were focused on infectious disease because that was the major killer. And among the non-communicable disease, I'm going to give the example of cancer and about also the examples of mental health. Next one. So this is for the example of cancer to show you that we don't try just to give the medicine. We accompany that with education, and we came from far. We came from a country where there was 0 oncologists, 0 anatomopathologist. Now we have 3 oncologists and we have 3 anatomopathologists. It's not a lot. So we had to create technicians that are capable and use some equipment that are capable to do some diagnostic and have the support of friends overseas. And we send the sample, we take the sample, we take a photo of it, we send the photo to the Association of Anatomopathologists in the US, and we got the answer 2 days after, when those we have here have a problem. So even when you create cancer opportunity for the population, we need to overcome what we don't have. And we need also to not say only we are just going for prevention, eat well, don't do that. Cancer exists even for people who eat absolutely well and for people who have really one of the best lives. So prevention, of course, but give access to treatment. And in front of our campus, there is the only rural center for cancer that exists and who works since, who provides services since 8 years now. We have 1 center for radiotherapy in the country, and we hope that we'll have more to come. This is in the center. It's in Butaro, where the hill just in front of our university, and it was the first cancer facility in the country. And I said the only one in rural area, and it has treated more than 8,000 people now. Next one. For mental health, as you know, Rwanda was very traumatized after the 1994 genocide against the Tutsi, and at that time we had 0 clinical psychologists, 0 nurse specialized in mental health, and no psychiatrist. So we had to really make the people working for the people as a support, and it works well because the countries became very resilient, and now we are not very far, but we have a psychiatrist in each province. We have capacity, every doctor has been trained to provide some support. And in each health center, we have a nurse that is specialized in mental health. Next one. So the social determinants of health were at the center of everything we did. And also the task shifting and task sharing. Meaning we don't have specialists, we give to general practitioners or general nurse the capacity to provide the care, and the community health workers the capacity to provide the care normally elsewhere provided by nurses, and it works. It works under supervision. It's not that they have to do that, they are trained before doing that, and when doing it, they are supervised. Next. So, gender equity, we have made some studies since, not on Rwanda, on other countries like Nepal, Peru, Senegal, Ethiopia. And we have seen that gender empowerment is key in the survival of the vulnerable of a community. And you have up to 37% life saving of children if we empower properly the woman. And you can do that by make primary school mandatory. And in the beginning, it's a fight with families because they're used to have the girls working at home and they don't know how to reorganize. So it's mandatory in law. And at the end, you also a big campaign to do that. And now there is an equal access to education. Still, girls doesn't go enough in scientific area, and we are studying why, and we are working on that. For the parliament, I told you, 61% of women in parliament, and in cabinet, we are almost 50%. Next one. So we did all this with a lot of hope and optimism. And another day we will discuss how optimism changed the outcome in health, and it's serious. Ownership, give the ownership of the health, community health to the community. Using implementation science, meaning reflect before what are the context, what are the solution elsewhere, how can we adapt them with the money we have and the people we have. So adapt the strategy and the evidence-based intervention based on science. Find a strategy that can make this available to your people. And collaboration. Without collaboration, we'll have done nothing. And in here I put PPCP because it's beyond public-private partnership. It's public-private community partnership because the communities are building with their hands, finding the stone to build health facilities. And we have also the churches that own around 20% of the health facilities in Rwanda. But they give the same services as in the public service. And in exchange, the government pay their staff and buy the equipment for their hospital at the same rate as for public hospital. So it's this collaboration at the service of the population that has allowed us to reach where we are. And of course, sharing what we learn, but also a lot of dialogue across communities, across sector, and with the people we serve. Next one. So then happened COVID. And because we had already an equity lens, I told you about the mutuelle de santé. Those who doesn't are poor pay nothing. It's 25% of them. The majority can afford $5 per capita. People like my mom pay $7 per capita. So you pay according to your revenue. It's a solidarity approach and evidence-based. And with COVID, we had the same approach. And for this, when we learn what happened in China, first of all, we blocked the plane going to China. We had one plane, Rwanda, going to China. We learn a lot. Not everybody, us at the University of Global Health Equity, but also the people in the Ministry of Health. What is this new virus, this new disease, what to do? And what are the evidence-based interventions? They are very simple. Next one. And using, based on the strong leadership we have nationally, the trust we have from the population, the health services we have already created, and the system of education we use through community health workers and as a pyramid, because you have the teaching in hospitals that are teaching the district, who teach the health center, the doctors, and the nurses teach the community health workers. Using all this infrastructure that was created and immediately adapt the policies, the strategies of the health sector to what is needed. Next one. So this is what we learn after, that COVID is not an equalizer. On contrary, it highlights more the inequities, equities based on race, and equity based on other vulnerability for the poor. They are suffering more, and also that countries who have overcome it in Asia before it came in Africa, in Asia and in Europe. If you want to lock down, our people will no longer eat. The majority of the people are in the informal sectors. So if we want people to respect the lockdown, we need to respect their basic need and cover it and plan for social support. And also identify who are the population at risk. One of the most important things we have learned through Ebola, that in countries like Liberia, people have died as much due to the lack of primary care than due to Ebola. The death of women because they had again to deliver at home alone without qualified personnel. And the death of the women who died from Ebola, there was no difference. So we cannot be ready to save people from COVID and let them die from lack of primary care. So also how to protect the primary care. Next one. This is something to show you that for all the listeners here, there are some countries who have done well. And those countries is not by coincidence, are run by women. So whatever place you are, the empowerment of women is not a joke. It saves life. Next one. So the what for COVID, we knew that the evidence-based intervention was washing hands, testing, do active contact tracing to avoid the virus to spread in your community. All those positive have to be quarantined and suspects have to be isolated. We need to prepare a lockdown to be ready to close the borders. And I told you that Rwanda has no port. We have no sea. Everything comes by plane. And today, March, 3 months that all the planes are stopped. We have just resumed, the plane has just resumed last night. So during those, and also all our neighbors are not apply the same principle to deliver care. So truck coming from Kenya or Tanzania have to cross also Uganda, 3 countries, meaning there is a huge risk to bring for people who are mobile like that to be source of infection. How are we going to do that? And also, how are we going to apply social distancing, having enough PPE, having enough equipment when people are sick? So transport was a constraint. The fact that Rwanda is in the middle and a hub of transit was a constraint. The fact that there is no access to running water all across the country was a constraint. And also the financial instability of living in an informal sector. And the facilitators was our leadership, the system we have created, the solidarity we have created, the trust we have created, the access to internet across the country. Next one. And this to show you how we have overcome all the barriers. For the transport, we keep the cargo, not the plane transporting passengers. For the borders, we have put control testing at each border. And at a certain point, we had so many truck drivers that were sick. And when they are sick, we hospitalize them in Rwanda because they enter in Rwanda. So we proposed to the company to have all their trucks have to have GPS. They put it. and they have to have trucks both sides of the border and download the goods before crossing Rwanda to another truck and drive inside Rwanda, because people who came had to have 14 days of quarantine. It was not working for all the goods. So with the GPS, we know where the truck is. I have to say that even when the truck driver stopped to do something on the road, and if that truck driver is find positive after, all the people surrounding that place where he stopped will be tested. And for this, we had to collaborate with the custom, with the security organ, and with the sector in charge of ICT. Next slide. We had to use data, and all the countries are using data, that's true, but not data we want to hear about, data that are true. And every day the Minister of Health is releasing by Twitter the data, Twitter, Facebook, and an official report every day. But we know also in which place of the country the new cases come from, and which place of the country are locked down and why. Knowing also that people are poor, how we bring them food is just by, there is a special budget for that, and each head of village, each village has a head. My head of village is 2 roads below mine. They are in charge to know who are the poor who cannot feed themselves or their family. They are accountable of that. So accountability of the Minister of Health, accountability of the head of village. Head of village report to local government, and they make sure that this works. If not, poor people will not lock down to make other people, to keep other people safe. You can see the second photo is the photo of the airport in January. There was no social distancing, but everybody had to take his temperature, say where they come from, which plane they have taken, which seat they have, where they are going, what was their phone, so that if we found one case, we can do a contact tracing immediately. So we started in January. And that's how the first case was in March. Immediately, everybody knew what to do, because all sectors have been contacted, the media, the churches, the private sector, transport, all the sectors have been concerned, the youth, the women, they have been consulted and informed of what to do for the first case, and the country was in lockdown in less than 24 hours. We, at the university, we locked down everybody inside Butaro, keeping there only the people needed, the others went back home and worked from home. So the border were controlled, the border were closed, there was a multi-sectorial collaboration, and everything was integrated in policies and guidelines, and it was rule to do, meaning if the science tell you to do that, don't try to invent another type of truth and go and do something else. And there was a focus to keep primary care working. So when somebody is suspected, the person doesn't go to hospital. They just call a number, and an ambulance comes, take the person for testing. If the test is positive, we have all the results in less than 24 hours. If the test is positive, the person is kept. Treatment starts early. They don't go to the hospital when they cannot stay home. They are not tested when they are really sick. They are tested when they are suspected. And the contact traces isn't. Because they don't go to hospital, there are places identified for COVID isolation and COVID treatment. There are no risk for the people to be infected in an ordinary hospital. And because of that, primary care continue. Next one. So we promote innovation also. In the airport, you have those little robots circulating since yesterday. And when they see somebody without mask or somebody with fever, there is an alert. I talk about the accountability of leaders, and I also talk about the way the entire health sector work around that. Community health workers are not more at risk to be near people infected, because when somebody is suspect, they all have a phone, the community health workers, and they call for testing. And the focus on equity is to support financially and for food those who cannot do that for themselves because they are too poor. And next one. Also, I told about the fact that we need to know our context, the evidence-based intervention to do and how to implement it. Many people transport in Rwanda are done through taxi moto. And there are teams across Kigali who are testing them regularly because they are so near the client that if one of them is sick, the spread of the disease have an avenue there. So there is also testing randomly in the communities, and we have adapted testing practice according the sector we want to protect and the place in the country we want to protect. Next one. So we don't know, nobody can know which will be the next epidemic, the next outbreak, the next pandemic, but there will be. And the fact to work, focus on equity, on solidarity, and also on the 4S, meaning create system. Think about the staff, what to tell them, study the science, and make it available at all levels of the health sector. Order the equipment, and we all know that having equipment was a nightmare for all the world. But we started in January. We were infected in March. And even though I believe that in the entire country, we don't have more ventilators than 2 hospitals in the US. However, because our first line is to avoid the virus to spread in the community, all the people sick, we can absorb them as they come. So, and the 4th S is the support of people. If you don't support, if you don't have equity approach, if you don't create solidarity and support and compassion, and if you are not evidence-based, you have problem to make it. You miss one of them, you may miss all. Next one. So, because there is no equity in health without equity in education, that's what we teach at the University of Global Health Equity. Next one. Next one. So we really want to link the global start where you have your 2 feet, but the problem to solution, and not focus really on symptom or what you see socially, but always have analyze it as a systemic issue, and bring not only together doctors and nurses, but also nutritionists, labs, and local leaders, and even beyond. And knowing that everything is not at the bedside or in the exam room, many things have to be worked on in the community. And I know that with Carol, you do that at Rush University. Next one. Also that most of the time, leadership is not taught, especially in countries like mine, but also in the US. Nurses and doctors have to take leadership decision, leadership position, and they are not educated in management. So every person, our doctors, will all pass through the Master in Global Health Service Delivery, And that master is 1 year, where a quarter of it is really leadership and management. Next one. So we have the objective to radically transform global health education and health service delivery. Our objective is better care for everyone around the world, especially providing equitable, quality, holistic care to all, but focus on the vulnerable. Next one. So we want to be a leading university, like all the university, but educated our students to be a smooth changes of the place where they live. They can be the next ministers. They can be doctors in a district or in a remote place. They have to be capable to repair or to create the health sector that doesn't exist there. Next one. So this is our campus. You just see a portion of it. And we plan to extend it to accommodate more education. And below you can see this is Butaro Hospital, where that we are going to increase also to serve as our teaching hospital. Next one. This is young people that are part of our inaugural cohort of medical students, and you see that they will all go through the Master in Global Health Delivery as well. Next one. We prioritize gender because in the other universities there is only 10% of graduates that are women. So we decided to make a statement by taking a minimum of 70% of women, girls, in classes of for medical education, and 50% minimum in all the other masters. And make sure that our students come from all the places in Rwanda for the medical education. During the 3 first years, all students will come from Rwanda, but we are opening up to the region and after that to the world. For the master program, we have already more than 23 nationalities. Next one. So we are graduated. I'm not going to talk about the past, but we are graduated next Sunday, our 5th cohort of Master in Global Health Delivery. And where we stand now. Next. We have now an institute of research for clinical research and implementation science. We hope to open the population research soon. We have a center of nursing and midwifery. We have a center of gender equity that support integration of gender equity across all curriculum and everything we do, but also are teaching how to do that for other sectors. We have community health and social medicine. We have a center of community development and engagement, and we have also a center of equity in global surgery, and we have what is new, an education development and quality center for faculty development, for assessing innovation in education and in research, and also monitor and evaluating what we do, because we need to know if in 5, 6, 7, 10 years, our alumni are what we teach them today, it's still accurate, so that we can adapt the education to the need of today. Like already we have everybody certainly have changed the education they give, because we want each and every doctor we educate and nurses to be capable to manage a threat like COVID, or to advise the leaders how to do that locally and nationally. Next one. We have partners, and soon we are going to add Rush. You can see that we have partners from Asia, Europe, and America, and also Africa. Next one. Those are, you go too fast now. Those are the financial support we have so far, coming from Cummings Foundation, Bill and Melinda Gates Foundation, and also we have put the bigger one there, but for scholarship for the student, that is something that we do. We don't want a student to be that are talented to not be capable to come because they don't have the money. And also the quality of education we give, very, very few Africans can pay for that. So we decide to make medical education for free. Of course, it's not free for everybody, so we need to mobilize the money. And in exchange, because we educate for better service delivery, they sign a contract that they will work during 9 years at the service of needed people. We don't care who they are. There can be Aborigine in Australia, street lost people in Boston. Rwandan have to work 5 years in Rwanda, and after that they have to work another 4 years where they want in the world. But for people in need, they keep down their salary. So they can be the head of the UN, we don't care. But they have to pass good policies and make good advocacy for the vulnerable, for better access to care for everyone. So thank you. This is what I wanted to share with all of you.
Wow. Well, yeah, I mean, I see all these images of people clapping, so you just have to imagine all that, Anya. Thank you, thank you, thank you. That was inspiring. It was thought-provoking. There are so many lessons for us in the U.S., and I've written some of them down, and I know I've missed a whole bunch. You know, the importance of having hope even when things aren't going well. I think that's a good message for us. The importance of strong and trusted leadership. Really, without that at the national level, without that, it's very hard to make the kinds of improvements that you're showing. The focus on the vulnerable, especially vulnerable women, the gender empowerment message, and you know, as a scientist and an educator, your focus on science and on evidence and on the importance of education as central to advancing all of these goals really resonates. So anyway, thank you for all of that. We're going to jump into the question session now. We have about 25, 30 minutes for that. And Dr. Crane, Dr. Stephanie Crane is going to manage that question session. But just before I have her introduce the question session and before we jump into it, I just wanted to introduce folks. And I think we have, I don't know, close to 300 people now on the line. Just wanted to introduce folks briefly to Dr. Crane. So Dr. Stephanie Crane is originally from Lisbon, Portugal, and she serves as the director of the Office of Global Health here at Rush. She is founder and president of Community Empowerment, an NGO that works in Haiti and the Dominican Republic in community-based sustainable medical homes and in global surgery. She's chief of the Division of Community and Global Health Equity in the Division of Internal Medicine and oversees the Global Health Fellowship and Residency track that we have here. Dr. Crane matriculated with us at Rush Medical College and completed residency in internal medicine here as well. In addition to her academic work, she has an internal medicine practice, which keeps her pretty busy. So with that, I'll turn it over to you, Stephanie, to introduce the question period and manage the questions for Dr. A.
Good morning, good afternoon, I should say, everyone, and thank you, Dr. Gabriel. Professor Binagwaho, thank you for an extremely informative and inspiring 45 minutes. I echo everything just said by Dr. Gabriel. So for those of you here in the audience this afternoon, a couple of quick reminders. We'll be starting a 30-minute question and answer session. Professor Binagwaho will only be answering questions for the next 30 minutes, so please get them in now. Once the time is up, we will no longer be able to take any additional questions. If you have a question, please click on the question mark above your video picture, and the Q&A box should appear there. Type in your question, and I will read your question out loud to Professor Binagwaho, and we will then await her response, and any other engagement, we will take it from there. So I'm sure there's lots of questions. Please, everyone, feel free to join in. So while we're waiting to get the questions started, I actually had a question, so maybe we'll go ahead and start with that. I was really taken with your comments about trust at the beginning of the talk. And trust between the population and the government health system is an issue that many countries face. It's one that we face here in our own country. And I was wondering what you would say were the key elements early on and as this evolved in developing that trust between the population and the health system in Rwanda.
So the big element of trust that exists, it's the accountability, meaning if you are a minister and you take a decision that harm the population, it happened. You will pay for, you will be accountable to that, and the population know it. And also being available and never lie. Let me give you an example. We introduced HPV vaccine in 2012. The population was still not really informed about what cancer is. Second, the population was not informed that the woman have a cervix. They all knew that the woman has an uterus for explaining, go and deliver in health facilities. If the baby is not well positioned, you can have a rupture of it. So uterus was known by everybody. Cervix was known by nobody in the country. So you had a vaccine that treated a disease not known for a part of the body unknown. If you don't have trust, why do we do that? But how do we build trust? We don't go to the people and say, you know, you have a cervix. No. We just go first to the spiritual leaders and explain to them, this is the situation of the world. This is the cancer in Africa and Europe. This is what WHO says and what CDC says, etc. And it's horrible and too late, etc. And this is what we can do. After that, we go to the teachers, to the parliament, to all the leaders that exist. And when they're all informed, then we start radio campaign for the population. And the population has, what is this? It's true, my wife has a cervix. And the pastor said, oh, but yes, God gave you your wife a cervix. And that means we all speak the same because we take time to explain. And even the media, you have a meeting with media. And because it's school-based, you make sure that there is no teacher who is not informed. There may be a glance, but they have to have received the true information from you based on science. So that's how you build trust. And first attempt, 96% of parents said, we want our girl to be vaccinated.
Amazing. There's a follow-up question to that, which I'm going to read. I love the concept of trust as a social determinant of health. My question, too, is where do we begin in this country where there is so much existing mistrust?
So you don't believe that in Rwanda, mistrust was not there. I start my presentation by the sad reality of the 1994 genocide against the Tutsi. I don't believe that at that time, I came back 2 years after, like Sherin told you. Don't believe I had trust. You know, when there was a big noise somewhere, I was really jumping, etc. And after that, the leadership is key. When the leadership explains to each and everyone, you know, there are people who have followed bad leaders. You need to forgive them, etc. So you start by telling the truth. You have a country that is highly divided. It's time to recognize that. But the issue, you don't talk about it. People are revolting and go and break more. You should do what we have done, sit and tell the truth. It's harmful. it makes you cry. It obliges you to see your people, your neighbor cry, your family crying. It obliges you to tell how bad the people are. But if you don't put that on the table with the objective of to build the future, you will never solve your problem with the native Indian. You will never solve your problem of racial inequality. How do you want to solve the problem of socioeconomic disparities? There is and the backlog put on the table and talked about honestly, frankly, without want to protect somebody from the truth, you will make it. So start by talking about the true problem that exists. If not, don't believe something. In many Black brain, there is this fear of those Black people who have been, say, treated for syphilis and were just watching dying slowly, and the justice system acquit the doctors. You see, you need to talk about all those things. If not, people will believe it will happen again.
Thank you for that. And thank you for mentioning the word forgiveness as well, because I feel like that's definitely a concept that we have to a little of in this country and can learn from.
Absolutely. And I read this morning that it's not because you are not racist that racism doesn't exist. But you need to talk about it, and you are not necessarily responsible. You know, I was afraid in the beginning. To tell the truth, when I came here, I had little girls, a little adolescent. I was afraid for them to go and play with children of killers. And when you understand that those kids have nothing to do, and if you want them to flourish in society, you need to give them a hand and a chance. You transform their parents as well. So forgiveness is key, but it starts by telling the truth. And also those who misbehave to ask for forgiveness.
Okay, thank you for that. Moving along to another topic, there's a question here about selection of female candidates. Let me read this. Have you had pushback from male leaders on the over-selection of women for the university programs? If so, how did you deal with this?
You just have to yes, we got a little pushback, but not so much, because first of all, to come to work with us, you need to be focused on equity. It's a big part of the interview. But this is not really equity, because 70% of girls for medical education, it's a contrabalance. And when you explain that it is a statement to tell the world, at least Africa, that we don't do enough, with the hope that we will reach 50-50, they're great. They're great. So again, you need to make people participate in such a decision and be a good advocate. I have to tell you that big thing we teach to our students is to be good advocates, because they need to convince people above them, people at the same level, but also people they want to serve. Because if you don't convince people you want to serve to take your services, they will not come.
Okay, let's see. Moving on to a question about telehealth or mobile phone health aspects. So this person is inquiring as to whether you have or use any telehealth or mobile phone health aspects in your program, I think specifically around COVID prevention and treatment.
Yes, I told you, first of all, that everybody knows which number to call in case you suspect or you have you see a case and you want to help. Second, for the community health workers, whatever place they are, they all have a phone. We have now something like 50. We have 4 per village, so it's more than 50,000 community health workers. They all have a phone, and in this phone they have app to alert. Alert on anything. Today, COVID is in mind of everybody, but sometimes it's Ebola, other time is anything. So an example, if you have in a family or in a couple of houses profuse diarrhea, non-explained, they call. There is a rapid SMS system, there is an alert system, and the national lab sends people to see because we have neighbors with cholera, etc. So yes, phone and mobile tools are in the center of everything we do. And like now, it's absolutely not advised to change cash or money, mobile phone, mobile payment. And with COVID, all the service providers were obliged to subscribe to mobile money to improve the social distancing. So it's not only in the health sector, but all this is for COVID.
Wonderful. And just to follow up on that, in terms of phone access, does the majority of the population have access to mobile service where they would be able to avail themselves of that?
I told you that in each village we have 4 community health workers, and all them has a phone for free, just for use. So if you have a problem, you can use their phone. If you want to pay, if you want, but the penetration of phone across the country is more than 75%.
Wonderful.
It's not, there are still 25% who doesn't have, but there are still people in the village that have phone for service, because I'm talking about health for people for 200 houses, but we have also the anti-corruption people who have a phone. We have also the people who help in agriculture. We have also, so there are phones that are there, and nobody can say, I needed a phone and the community health workers refuse it to me. No, doesn't matter because it's for free.
Excellent, thank you. Okay, another question. How do you work with local schools to educate children in health issues and create a pipeline to the impressive programs of UGHE?
So we don't go to primary school yet. We are not enough for that. We go to secondary school, and we go to make it known, to go and present the program with the hope that we will interest the best, like all. But also we do beyond that. All our students have to do community practicum. And some of them do through sensitizing children, etc. We also participate in other programs like for mental health, for other type of sensitization. They will. The best thing is to be at service of this type of education. The renown will come or will not come, this is secondary.
100%. Thank you. Okay. Next question. For promoting equity, you spoke of a concept of focusing on the most vulnerable. If the grandchildren of the poorest woman is safe, then my grandchild will be safe. Can you say more about the focus on the most vulnerable when resources are so limited?
When the resource is limited, you start by the vulnerable, because other people may afford. So if when you start a new policy or a new vaccination, your question is, where can I find those who are the most difficult to be reached? And when you find the way to do that and manage to do it, make sure you reach everybody. So when you do a policy, and when you know how to do that with science and with the evidence-based activities to make it, you show the strategy that will help you to reach the most vulnerable. And you don't do that alone, because people in the community know better than you. So when we decide how to vaccinate for HPV, for example. We talk to community health workers and ask them, so how can we find those who doesn't go to school for a reason because handicapped or sick that day or whatever? They put the program together in a minute, saying, so that day of vaccination in our sector, we will make known to all the village, we want to know where the girls of 12 years old are if they are not at school. And they do the list, they send. And we send the vaccine to the nearest health center, and the parents come when they can, or the nurses go. So that means there is always a solution, but whatever you do, because in many countries what happens, the objective is to serve the majority. The objective we teach is to serve the most vulnerable. Then you'll get them because the majority of the time they are left out. And the others will be served.
Thank you. So I had a question regarding testing. I was very impressed about your comments about early testing at the borders. Did you have any issues with obtaining testing and having to make any decisions about rationing early on and as this progressed?
Yes, of course, there was not enough testing in the world. And first of all, around January, we had to equip ourselves to be capable to test because test of COVID was even not known in the world. What happened? All the hotspots are served. First, it was the border because it will come from outside. After that is contact tracing, active contact tracing, with not allowing less than 85%, meaning if you lose 15%, you are bad. After that, the population at risk, the people who move a lot in the society, like I talked about the moto drivers and the taxi. Those people have to test every week. So keeping the test for the population at risk, identify not by you only. All sectors are there. Who are the people at risk in your sector? So at the border, all the borders, we had the truck drivers is systematic, taxi drivers, etc., and people who are working with either in the lab, either with people who are sick. They have to test every week. And now you can also ask for a test. There is a little bit more tests in the world, so they are available. You can order. You just have to say, I'm not at risk, but I want to travel. I want to have my test. So you have to come. It's 2 days before. You have to ask and go 2 days before. You have your test in 24 hours. And in any case, if you want to come in Rwanda today, you need to come with a negative test, PCR, less than 72 hours. However, landing, you are tested again. And you have to go to isolate yourself in a hotel that is listed, hotel that take just people who accept to isolate themselves. So don't go and socialize in the bar. No. You go for isolation. And if after 24 hours, your second PCR done in Rwanda is negative, you can go. Now, if you didn't make a test before, you need to wait another 4 days, and do another PCR. So you need 2 PCR to just go and travel in Rwanda. So with this, I think the population is safe. And we have managed to, without rationing, do all the needed tests, but to have a focus on the people at risk.
Wow. So much for us to learn from so many things you said there, lots to unpack.
But this is implementation science. You know what are the factors, you know what are the evidence things to do it, you chose the strategy that you can afford and that protect the people. Never get.
I have a question if there's a minute, Stephanie.
Yes, please, Dr. Gabriel.
Yeah. So you talked about so many things. Could you say a little more about your contact tracing effort that you stood up? We've been very challenged in this country to have, and even state by state, to develop effective contact tracing approaches. Maybe it's just a function of numbers, but how did you approach it?
So it became a function of number when you are overwhelmed by the number. But Sherin, if you do contact tracing, at the first case, you are never overwhelmed by number.
Yeah.
You got a point. So first of all, you need to put the science at the front of any decision. First cases, you may say, where do you come from? What are all your contacts? And test all of them. Because if you don't, already it's spread in the community, then you are overwhelmed by the numbers. And also the fact, the trust issue is key. Because when you search, people will not hide. Because they know that they will be safe. They will be in a good quarantine, well fed, and with a lot of chance to recover. You got the point. And they be loved as well. There is something that when you have trust, as a loving person, you do your best to stop the spread.
Yeah.
When you are not trust and you say, okay, you have to pay the test, people who doesn't have money, so they say, okay, I will hide it because I need to feed my kids, etc. But the test was free. The quarantine was free.
Mm-hmm.
And if isolation, you cannot be fed, the community fed you, and there is a national budget for that. So create the social contact tracing, work only in that condition.
Yeah, absolutely. Back to trust.
Back to trust.
Yep.
And can I tell you something good, Shane?
Yes.
The global study done by Wellcome Trust have shown that the country where there is the highest trust in the health sector is my country. And I hope it will continue because this is what has helped us to build what we have done.
Yeah.
So I think maybe we have time for one last question here, just to follow up on this. So the question is getting at, given the fact that we sort of missed the boat early on with the first case in terms of contact tracing, are we too far gone in this country with contact tracing? And do you have any suggestions for how we could get back on track with this?
You can go back on track simply by following the science. What does the science telling us? If somebody is sick, first of all, treat the person, save the person. But also quarantine the person. And there are some studies, I need to read them again, but because it seems so high. Put a mask when you go out. You know that the decrease of risk of spreading the infection is so high. So this you can do. Isolate the people who have been in contact. Make the test accessible. Go and actively test in population at risk. If Rwanda can do that without $826 per capita, tell me what the US can do with 50,000 per capita. You can do that, and the issue is I don't understand your law. In Rwanda, if I go out and say that masks make people sick, and I have no evidence scientific and for that, and the scientific evidence say the contrary, and I know that it will harm people, I will be accountable in front of the law. I'm not allowed to say whatever I want if it harms people. So I don't say that you are a lost cause. I believe you are not. I just say that you have all the possibility to reverse things even before a vaccine. But there is not 100 ways to do that. Truth, science, protecting the vulnerable, use the system, and and give the support needed.
Wonderful.
I think that's a wonderful place to turn it back over to Dr. Gabriel. Thank you so much.
Thank you so much.
Thank you. And thank you, Stephanie. And actually, just before we close, I'm going to ask Carol if she had any closing words, and then I'll close it. Thank you so much, Stephanie, for managing the questions.
Thank you, Stephanie. It was a pleasure.
Thank you, Stephanie, but thank you, dear Agnes, for joining us today. Your experiences and humanitarianism are an important education for us all during these very difficult times. But you have inspired us today with hope. We've got so much work to be done, but we can do it. So your guidance, we will remember your guidance, and we will talk to you again about more of the things that we should be doing. And we look forward to working with you with Rush and the blood program that's in the works. I cannot thank you again. And you know what? I miss you. And so, big hug here.
A virtual hug.
At least we can see each other. Anyway, but thank you so much. You are an inspiration always to me, and I'm sure to all these people, because the questions were just amazing. I thought these were the best Q&A that I've ever sat through. So anyway, be safe, be well until we see each other again.
Thank you so much, Anya. Thank you. It wasn't just the questions; the comments are just amazing. Have a nice morning, afternoon. See you all soon. Bye-bye.
Thank you, Stephanie, Sherin. Thank you, Carol. And thank you, all of you, for listening to me. It was a pleasure to exchange with you. So it's like fresh air. Really.
Yeah.
Thank you.
For us as well. Take care. And I thank the team that helped us put all this together in both countries. Thanks a lot.
Thanks
Bye,
a lot.
everybody.
Bye.
Bye now.